you, Dr. Kaushik, and I think I've been given a very fancy title, tips and tricks. I don't have such fancy items to offer, but definitely I'll share the practices that we have at Arvind, and of course, it will be applicable for all the ophthalmologists. So the first thing I wanted to share was balancing the manpower. You should never have an excess because there is a definite decline in the efficiency of the performers, and also there's a lack of accountability because there are too many people handling the same activity. At the same time, if you have inadequate people, you have an exhaustion and the quality offered is poor relatively, and there is an inefficiency eventually. So for us to have a good productivity out of people, you need to have a right balance. You need to have the right number. Now, for the consideration of proper manpower planning, we need to have a proper role clarity. That is, you need to categorize the people. You need to give a proper role clarity as to what they need to be performing, and also what activities needs to be performed by those individuals. Because often you give a title, but you don't give them the exact activities that need to be performing. They end up not performing, and the expectations at both ends are not met. And then you also need to analyze the performance. That is, you need to know what volume they need to be handling in order to do an appraisal later on. So you need to know the workload as well. And the most important thing as of now, what we see is really relevant is who should be performing the activity, which means a lot of tasks have to be shifted to other people. So it's just not the clinicians. It could be the clinicians, it could be the administrators, it could be the paramedical staff, and it could be the support staff. And each one needs to have a role clarity with a proper job description, and also clearly indicate to them what is expected of them, how much can be done. Now, we also need to understand what is the volume that we are tackling. It could be just about 50 to 100 patients in a day. What is it that we are going to handle? What are the activities that we are going to perform in our clinic setup or in an institution or at a hospital? It could be any grade, but we need to know. And what is the expansion that we foresee in the near future? And also anticipate an amount of attrition. You can base it on your previous experience, or you can also make some kind of an assessment, which I'll talk to you in a little while. So now you also have to match your intake based on your attrition. So intake, you need to take the right person for the right job. Now, after having an interview or having several conversations with a person, you probably would think that this is the person right for that particular job. Let me take a simple example of an MLOP. I just want to take that example because MLOPs are very critical in our system. So you would take a counselor who is very verbal, who can talk and can be a little aggressive in terms of spelling out things very clearly to the person across. So in our case, if it is a counselor, we would think of a person who is more verbal, is very good in communication. So you might have chosen that person for that particular job, but you need to spend some amount of time orienting the person, training them, and also mentoring. They cannot be super duper in day one. They have to be oriented as to what is expected of them. You have to train them in that particular aspect and then mentor them. The same holds good for all categories of staff, be it a clinician, be it an administrator, be it a paramedical staff or a support staff. All of these people require a proper orientation, a proper training, and good mentoring, hand-holding, and eventually letting them go to work independently. Now, talking about attrition, there could be an active attrition and a passive attrition. An active attrition is like one anticipated, like people are there for, like for example, if it's a doctor, a postgraduate would probably stay for a couple of years, a fellow probably a couple of years, and then in like 2 to 3 years down the line, they would be leaving us. That would be an active one. I mean, we foresee it and we let them go. Passive would be you have to let them go because they are a misfit and they're not doing adequately well. So you may have to let them go. Now, we have as far as the doctors are concerned, we have the consultants or the medical officers and the trainees, which could be in the form of residents or fellows. The consultants would concentrate on diagnosis treatment, which is very, very crucial, complex surgeries, and most importantly, they would be engaged in training and mentoring and research activities. All of these are very relevant and pertinent, and you will have to ensure that this is an ongoing process to attract the residents or the fellows who would be initially engaged in examination, surgeries, and outreach activities. So this would be the work pattern they would be performing in the initial years. Now, you also have to balance the human resources in terms of the doctors to paramedical staff to the support staff. What we actually follow here at Aravind is 1:5:4, which is actually good enough for any setup, be it a small one or a large one. So the clinician is led to focus on the critical areas like decision making in terms of treatment, counseling to a certain extent, and surgery. The paramedics would spend more time in patient care, which could range from any activity in terms of recording the investigations to counseling the patients and also treating them whenever necessary. And the support staff would be helping us with the patient satisfaction. Now, the productivity of the staff definitely increases and improves only when there is a standardization. Each one cannot have one way of performing the activities. So we need to have protocols in place which are to be stringently evaluated and updated as and when there is an innovation or a technology or a technique that's new. Systems have to be put in place in order to ensure that there is a monitoring happening at all levels. And also, most importantly, whenever we talk about productivity of the staff, we also should ensure that there is an ideal environment that's provided for that particular staff to perform that particular activity. If it is a doctor, you need a good monitor. You have to provide them with the right equipment, be it a microscope or a slit lamp. It should be an ideal environment that we need to support these staff. And as it goes, I think most of us require a bit of monitoring, and in order to appraise and also give a proper feedback, we need to have proper monitoring system in place. For example, if you have to monitor a MLOP, you need to know exactly what she's performing. Like say, for example, she's a refractionist. How many refractions has she performed in a day? You need to monitor that. And how many of them are right? And how many wrong prescriptions has she given? So this is a place where it allows us to give a good feedback and also provides a place for appraisal. Now, there are opportunities by monitoring to create a system wherein you could educate the performers or the MLOPs to upscale them and also to provide some kind of a continuous medical education as well. So it is very, very important for us to have a monitoring system in place for all categories of staff, and also this feedback, if say a person is performing very well, providing the feedback, telling them that they're doing very well is a very good incentive for the performer. So it's very, very important for us to give that proper feedback, and a feedback can be given only when there is a monitoring system in place. Now, to manage attrition, we need to have the people align themselves towards the job, and for which we need to have an inclusiveness from the top management. It could be a manager, it could be a supervisor, it could be anybody in the system in the hierarchy. And inclusiveness helps them to be aligned to the job. You empower them. I mean, we have empowering for the MLOPs and the doctors at various levels. I think in the previous talk also, people have been posted in smaller centers to get empowered, and then they move on to larger centers where they get to move to a higher position. So all along, you will let them be empowered from a small scale to a large scale, which helps them to escalate themselves in their career. And as I mentioned earlier, create a work culture, and this culture has to be uniform, transparent, has to be flowing from top down, and create a supportive ecosystem as well. Now, the most important thing is create a transparency in their growth pattern, be it the doctors or paramedics. They need to know where exactly they're climbing on in the ladder. So when they know where they're climbing on, there is a motivation for them to work towards it. And you should have a space for them to voice out. Everybody needs a space to voice out. So we have systems like suggestion corners where they could spell out their grievances or whatever, and space for creativity. This allows them to be innovative and also helps them to be participative in the system. So somewhere my small innovation is there. It's been approved by the organization and it's working in all our hospitals, gives them a motivation. And the most important thing again is capitalize on the potentials of the individual and facilitate them to grow in a particular area. There are some doctors who are not happy doing surgeries. Well, they may be good in academics, they may be good in teaching, they may be good in research. Help them capitalize on those areas and allow them to grow in that particular area. But again, as I said, monitoring is very, very important, and giving them a feedback after having given them the liberty of choosing the area and working on that particular area. You need to monitor and give them a feedback. And when somebody is not fitting into our system, let them go, and that has to be graciously done. And whenever somebody wants to get out of our system, also you will have to let them go very graciously, because they might have various reasons. This is sending a kind of a, there is something that's going around in the organization. She had to go, he or she had to go, and there was such a gracious letting go of the organization. This sends a message around the organization. And also now, we need to also remember that there is something called another life to the candidate who is working at the hospital. So you'll have to engage in their performance at home also to a certain extent, and their well-being as well. You could engage them in social activities. You could create facilities where their children could come in. I have some camps for their children. All of these are activities which can be chosen based on the scale in which we practice. And of course, I put this remuneration last in the list because it really doesn't matter, as was mentioned by our Tulsiraj sir. Remuneration is not the only thing that people look for, but it has to be essentially market matched. So in summary, we need to have an adequate and appropriate distribution of manpower, delegation and task shifting for optimal productivity, standardization and process, protocols and training is very, very important. Engaged and empowered staff will remain motivated, and that's all we need to have for a proper human resource system. Thank you.
That was a wonderful talk, Usha. That was really good, and I'm very sorry I had to leave when during Dr. Kaushik's talk because I had to participate. You have to stop sharing your screen. Sure. I had to go to the management committee meeting, and I felt missing your talks was a big loss. So going on, I have some questions for you. I would want Dr. Tulsiraj and Dr. Kaushik, all of you all to answer this question. How many of them actually stay beyond their training period? And does the cycle of new recruits joining in more than compensates for those who are exiting out? I know all the most valuable lessons which you told us, Dr. Usha, but this people exiting the organization is happening. So how do you feel? Does it actually make a difference? The third question I have is, what is the male-female ratio of stability in employment? That is the third question. And do you feel that if you keep enhancing with training programs and teaching them new skill sets would keep them with you, or is it understanding the volume of work in your hospital and the kind of fatigue which sets in by the end of the day, it all becomes very routine?
So should I take it, sir? ED, sir?
Dr. Tulsiraj?
Should I take it, or would you want to answer this question, sir? You're muted, sir.
Dr. Tulsiraj, you're muted.
Yeah, Usha, you go ahead and respond.
Yeah. So for the question number one, attrition, yes, we do have a significant attrition. Overall is about 15 to 17%. It varies over the years. Now, if you talk about the doctors, you all know what the situation is. They get trained. They would stay there for a couple of years to get further trained. And as and when the new things come in, they get trained again. And there is a saturation for them. There is a plateauing of interest, and eventually they might want to move out to the hometowns. This is an anticipated attrition, and this is a welcome attrition. Now, coming to the MLOPs, we have a situation wherein they work with us for about 5 to 7 years maximum, and most of them would move on in their lives because of the societal implications they have as well. So another thing I would want to emphasize here is clearly indicators these MLOPs are particularly performing the skills, which is almost routine and monotonous, as you mentioned. Dr. Chitra was mentioning about the monotony. Yes, it sets in. Unless you give them a variety, there is some monotony set in for these candidates as well. So when they move, it's almost a welcome move. I think we would appreciate the move also. But if you have a candidate who can scale up and grow and is a good leader, we would like that candidate to continue, and we would give them a variety, change in the performance or change in the skill set that they need to provide. So they would become leaders in the form of either they would be trainers or supervisors or managers or coordinators. All of these is a possibility. For the doctors, it's a different ball game. They would have come from far off places. They would want to go back to their places. And I think, again, we are not compromising on our vision or mission. We want everybody to do their work. And if they're well trained, we're happy that they're leaving the organization after having a very good training and going places where they would be providing the same services. The same holds good for MLOPs as well.
Dr. Kaushik, you have any thoughts on these management aspects?
What Dr. Usha said, saying that at every cadre you need to identify the performers and the non-performers. The performers need to be groomed. Sometimes we may not be the best place for their career also. So you should not hold back people who may probably blossom elsewhere, because if they do well elsewhere, they will come back and do good to you as an organization. So that is one thing that we have learned over the years. The second aspect is when you're training people, we are often scared saying, oh my God, what if I train and they leave? But imagine the flip side. What if they don't leave and they are untrained? Then you have a bigger problem at hand. So today we have de-linked our training and the recruitment. So we train people, and based on the requirement at every hospital, they are welcome to recruit. And our belief is that if we have trained them well enough, our candidates should be much better than what the market offers. So we create a very competitive environment. We would love to have people from other organizations join in, because that brings in vibrancy to the organization also. Otherwise, you become too much of a single thought process entity.
Dr. Srinivas, do you have some questions? Srinivas Joshi.
He's busy.
He's busy. I wouldn't be surprised if poor fellow is having his lunch only now.
Just to supplement Dr. Chitra, what they both said, I think attrition is inevitable. So I think what is critical is having a pipeline, which I also mentioned earlier. So I think that's very important. And something which Usha didn't touch upon is onboarding, or what we call as orientation. That's again extremely critical, so that you bring in upfront alignment to the organization, to the processes and how things are happening in your own organization. So that's again very important. The third element, which again we have found to be very useful, we use the word empowerment, but it's really about respecting the employee, or more respecting their job. Like, for example, a high school girl who may be in charge of our operating room, which schedules, which does the planning, because a high volume maybe for 200 surgeries or more on a day. So she would be telling the senior most person, or even Dr. Ravi, who's the chairman, on how many surgeries he ought to be doing. So, and then that's routine. I mean, that's her job. So that's respected. So the whole hierarchy bit doesn't come in. So I think empowerment is something to do with giving respect to your staff, regardless of their status, because really respecting what they do. It's not the individual. So I think these are some things which you have to build within the organizational culture, which again, in terms acts on the employees in a very different way. So they really, I mean, that's what makes them feel empowered and also become engage with the organization, something that you mentioned, Dr. Chitra. Yeah.
Dr. Srinivas?
I have one question to Dr. Usha Madam, Dr. Tulsi Raja, and Dr. Kaushik. Do you have any, like say, for example, for HR management, do you have any policy? See, there are so many examples, like we get a mini CEX exercise or UC Davis professionalism excerpt, all those things where you get most of the things, whether they act like a team player, they are divided, whether they are in time. So what we are doing at our institute is, I try to grade them on the Likert scale. So I've given them the UC Davis professionalism excerpt and try to slightly modify it based on that and try to make a Likert scale and ask each observer, say for example, for floor level, take a manager who have to do that. But that manager will not be known. That means the people around them will not be knowing who is their manager, who is scoring around it. So what is the best kind of HR management system you people are implementing at Arvind as well as at Shankara?
Dr. Kaushik, would you want to go first?
So when you're looking at recruitment, again, at different levels, we follow different principles, so to speak. So at our fellowship interviews, interestingly, we have a psychologist who's part of our interview panel. So we've been doing it for the last 2 years because we realized that the DNB students and fellows actually have the most stressful time. So it is very good for you to know what their stress triggers are, what their positive, negative triggers are, and we found it to be a very good match. So we again have used multiple tools of having them write articles, having interactions, asking them about situations that sometimes they may lie, but it still works pretty well. In terms of the psychometric assessment tools that you were asking for, we used to use multiple of these tools for leadership positions, especially the unit leaders and that kind of positions, because these come at a cost, both in terms of economic cost as well as from evaluation costs. What we found to be most effective, honestly speaking, is to have 2 or 3 people to interview. Because I think what has been resonating through all the talks that we've heard is that the alignment to the culture of the organization is very, very critical. So when you have 2 or 3 people who have been part of the organization, they could be at various levels. When they interact very quickly, they can tell you saying, okay, this is somebody who can fit in or not fit in. Once you have the right attitude, the skills can always be taught. So that's something that we've learned again with time. And that's something that we're using. So we use very limited psychometric in recruitment. We use it, like I said, for a fellowship program more than for employees.
Yes, Tulsi sir and Usha madam.
Yeah, very briefly. We really don't use any of the psychometry tests for assessment and things like that. But then what we have put in place are a few things. Now, when it comes to training, it's done very rigorously. And then we also have 2 communication channels, which is actually IT based. One is where they are at freedom to report anything wrong happening in the organization, in patient care or otherwise, including near misses. Maybe mistake didn't happen, but could have happened. And then those things get landed up instantaneously at the highest level. Chairman, myself, Dr. Usha, half a dozen people, and they get also acted upon immediately. And almost always we look for a system fix rather than a person fix. Because even if a person made a mistake, we would recognize it is probably an outcome of lack of supervision, monitoring, or training. So we would go to the root cause and fix that. So that's created a certain healthy environment. And the second is much more at the personal level, wherein there's another portal wherein they can post what we call as a suggestion corner. The breakfast was horrible, or the TV timing was not enough, whatever it is. They would do it, or too many mosquitoes, whatever it is. But then again, the reaction time to start working on them is instantaneous. And quite often there will be some resolution within the day. So just giving that confidence that their voice is heard, and something will be done. So this is set up deliberately to cut through all hierarchies to land up at the highest level instantaneously. No, so that I think has been very helpful in making sure that there is a sense of staff centricity. No, and that builds trust over time. No, and that's been very helpful also.
Yeah.
And in small organizations, I think this is by default. You don't need IT systems. You just need to be sensitive to body language and whatever is there. No, yeah.
And you all have patient feedback systems, sir, because what we learn from the Western field
is
the Fitzpatrick evaluation, where they have shown that 80% of the doctors change their behavior is because of the patient feedback.
Yeah, that's very true, Srinivas. Actually, we do it in two ways. We have actually a team of half a dozen people who do it on a regular basis. The typical questionnaire method and phone calls and things like that. And I think something innovative that we do is every day we do 2 focus groups. Now, that means if it is retina service, they'll pick up 10 patients from retina who are willing. No, they are just more the patient's willingness to spend about half an hour with us. No, so they are led through a discussion asking about what went well, what we can do better, and things like that. And when this person is doing that focus group discussion, we will have a few people in the same department also sit and observe, because they have to listen to what patients feel nice about their work or their experience, and same way what they don't like about that work. And that's been extremely powerful in changing behavior. And then quite often we feed some of that into the training program. So that's been very powerful. Thank you for bringing that up. Yeah.
And that one more addition to that point is we also do this as a routine in the departmental meeting every week. The feedback, whatever is being gathered in terms of the MLOP's performance, the doctor's performance, every individual performance is rated, and then we are also
rating this, madam. The patients or the staff?
The patients will give a feedback to our feedback team, and we will be rated and benchmark against the departments, and this will be discussed in the departmental meeting every week. So they give us a clear visibility, and to the extent that the doctor was talking about something in the operation theater when he was performing, the sister came just right bang on me for syringing, things like that come out. And yeah, so those are very helpful for us because as you said, it has changed a lot of our behavior. And now the doctors and the staff themselves have changed in their body language because they know very well that it's going to be quoted somewhere.
True, very true. And especially in the digital era, if somebody goes and puts a bad review in the Google, then the management will definitely try to bring up on that doctor. That has become so scary nowadays for the doctors.
Not to penalize, but more to change the behavior and indicate that this is not a practice that is being appreciated in the organization.
Great. Dr. Kaushik, quick 1 minute, and then we'll end up this session.
No, I think the feedback is very critical. So we have different systems. We don't do focus groups, but we do look at identifying patients who are upset. So they can trigger a response saying they're upset. That kind of gets escalated up, and we then try and talk to the patient and understand why they are upset. And again, the attempt is to figure out what the problem was. Quite often it's related to communication. The doctor meant something, said something. Most of us have something else on our mind, maybe a complication of yesterday's surgical list that has landed up that has completely upset you. So the next patient does not get a smiling face from you. And he says, oh, that doctor was so grumpy. He was so annoying. He was so angry. He didn't listen to me. He had something else on his mind. So quite often just talking to them helps them. That helps. Again, from a system fix, often we find certain errors. Sometimes it is to do with the individual. And sometimes you have to take that hard call of letting people go. So if you think that there is an issue, let them know upfront, but you have to be consistent. So the same feedback comes to 3 different doctors. You can't treat it differently saying, oh no, he'll never do such a thing or she will never do such a thing. So you have to be very consistent. So that actually helps. Like Usha ma'am said, the transparency is very, very critical. And the minute you react to that, it helps. How much of the feedback changes behavior is very difficult, but what we keep reminding our doctors is there is a 95% chance that what you're talking is getting recorded, whether you have given permission or not. So be aware of that. And once it's on social media, it's on social media. You can delete the Google review, but somebody will rake it up at some point in time. So you have to just learn to live with it and behave that somebody is videographing you and recording you. That seems to be working well for us now.
Great.
So one more point I just wanted to add, just to help the youngsters. See, you have to trust people, but at the same time, you cannot be biased to any particular person. Sometimes we have this tendency to lean on to somebody in particular because they are high performers. But then we'll have to be very careful and very balanced about it. You need to trust people. At the same time, you'll have to keep in mind that we should not have any bias towards any particular person. That happens in a smaller setup sometimes.